So I guess there's two questions. One is, can you achieve meaningful use by simply connecting to the NHIN? The NHIN, like any other piece of technology, is something that will enable a provider to meet meaningful use. But if somebody connects to the NHIN but doesn't send electronic prescriptions, which may be one of the criteria, they may not meet meaningful use simply by putting the plug into the wall, if you will. It's really about creating the technology and creating the incentive for people to use that in an effective way. The second part of that question, how does this relate to the state HIEs? There has been a lot of recent work with programs that have been announced that have provided resources and support to states that are planning their HIE activities. We're working very closely with ONC to make sure that we have a coordinated strategy. Part of it is that because many of these activities are running in parallel, it's difficult for us to say, here's exactly the recipe for what you need to do within your state. I think instead what we have is a plan or a process in which there will require state engagement and input as we develop the versions of NHIN that will be able to support these activities. And so the relationship really is one of sort of collaboration right now, in that I think we need input from the states to make sure that we can meet the needs that they have for information exchange. And then we also need to work with them about the sort of the larger national objectives that we have with the HITECH Act.
We're out of time, unfortunately. There are many more online questions, and for those of you that ask your questions online, the panelists will provide answers to you directly to your questions, but they were so rich, and I wish we'd had the opportunity to address those questions as well. Thank you so much to Dr. Fritzma, Ms. Yeager, and to Dr. Lansky. This was incredibly informative, and we greatly appreciate the time that you took to share this with us. Before we proceed to the next stakeholder forum, I would like to recognize Laura Miller, who is in the audience today. And Laura was the initial interim executive director of the National eHealth Collaborative and was absolutely instrumental in the organization's success during those early months and years. And Laura, we want to thank you for that again. Just seeing you out there reminds me of the hard work that you did to accomplish that, and wanted to acknowledge you. The next stakeholder forum that we'll be doing now is, again, continuing with the NHIN 101, Introduction to the Nationwide Health Information Network. And for the next item, we'll turn to our board vice chair, Dr. Simon Cohn, the associate director, executive director of the Permanente Federation at Kaiser Permanente, to lead an interactive panel discussing the NHIN users. And I'd like to ask those panelists to please, if they will, come forward. The panelists will be talking to us today about several ongoing pilot projects that are utilizing current NHIN specifications, and will share with us why they feel that using the NHIN is critical to the success of their endeavors. Simon, if you would you please introduce our panelists?
Sure, Laura, thank you very much. I guess I should comment in just not only just introducing the panelists, but trying to introduce the session. I've been asked to both lead off the presentations as well as moderate. It is obviously a pleasure being here and obviously having the opportunity to share the podium and microphone with, first of all, Stephen Ondra, who is Senior Policy Advisor to the Secretary for Health Affairs for the Veterans Administration. We also have joining us, Brian Dixon. Okay, Brian Dixon, thank you. From Regenstrief Institute. On the phone, I believe, is Charlie Magruder from the Centers for Disease Control. And finally, we're pleased to have Liesa Jenkins joining us. She's Executive Director for CareSpark. Now, we're going to spend the next 30 to 45 minutes sort of talking some about our experiences versus early implementers of the Nationwide Health Information Exchange, and then moving, and this will be Stephen, Ondra, and I talking about our experiences with the Veterans Administration and Kaiser Permanente, and soon to be the Department of Defense. And then we're going to shift and talk about a project that's going on between Indiana and Centers for Disease Control and others, a planned implementation of the NHIN and the specifics of that. And then we're very pleased to have Liesa Jenkins talking a little bit as someone who is beginning to think about joining the NHIN. And I think her perspectives about why she might or might not want to sign on as we move forward here. And I hope I'm representing you correctly, Liesa. Hopefully there will be time left over for questions. And we obviously will take questions first from the board, and then from there, obviously, be happy to take questions as time permits from those who are on the web or calling in and listening to all of this. Let me first start with, as I said, as I mentioned, I'm leading off the presentation, talking a little bit about the Kaiser perspective, and the board has been talking about that off and on, sort of ever since we've started today around 1 o'clock. I'm obviously going to ask Stephen, Ondra to provide color commentary, as well as provide, I think, some of his unique perspectives from the Veterans Administration, since they're a long and valued partner in this whole activity. With the next slide, please. Am I doing that? Okay, please. Okay. So next slide. Just briefly about Kaiser Permanente. I think you all are pretty familiar with us. We are the nation's largest not-for-profit health plan. We are also an integrated healthcare delivery system. What all this means is that we not just only insure, but we are actually taking care of our 8.6 million members. We've got 14,000 physicians, Permanente physicians, 160 employees, 30 medical centers, about over 400 offices across 8 states, actually 8 regions, 9 states, and the District of Columbia. Next slide. We're obviously very proud of the fact that we've actually implemented electronic health record. I think something we share with the VA, though, using different platforms. This has been, for us, a multi-year effort. We lagged a little bit the VA in terms of that, of our implementation, but I think we've gotten there nevertheless. Last year, we received awards from HIMSS for this implementation, and at this point, it has been virtually completely rolled out. It's being used by physicians and other providers on the inpatient side as well as the outpatient side, obviously to help improve quality of care, coordinate patient care. Underlying all of this is, of course, the privacy and security of our members' and patients' information. And, of course, we also see this as an important tool to help ensure patient safety and provide decision support so we can hopefully help even further improve the health care to our members. Now, the next slide begins to sort of move into, I think, the areas that relate to both the VA and Kaiser Permanente. In the sense, I think we both see our electronic health record as a platform for moving to the next step. And the next step is really the NHIN and interoperability that we'd like to see extend, obviously, beyond our brick and mortars, beyond our walls, to basically help serve and support the care of our members, no matter where they may be seeking care. Also, of course, help us better care for individuals who seek care within our organization who are not members. And I think this is a conundrum that we've all had. But once again, having an EHR to start with enables us to sort of move to this potentially more sophisticated conversation. Now, Kaiser Permanente, as I mentioned, is across 8 states and the District of Columbia. And so for us, as we begin to talk about issues of interoperability and moving beyond the brick or mortars, it becomes extremely important that we are talking about uniform standards. This is not a situation where we want to see, well, a one-off for this health information exchange or this set of providers, another situation for another state. To really be able to leverage what we have, we really need an increased commonality of approaches. That's, I think, been for us one of the exciting parts about the Nationwide Health Information Network, about the fact that it is standards-based, a single set of standards-based, and has made us really one of the strong supporters of this initiative. We are obviously one of the NHIN grantees, and we're one of the early adopters. But what I will tell you is that we've been excited enough by this effort that the monies that we have gotten from the federal government as grantees have been really very minor in comparison to the amount of dollars that we have contributed and invested in our organization to make this happen, because we really think it is an important strategic initiative. And I guess, Steve, I'd ask you, do you have any comments about this? Or?
No, you know, I think that the value, there's the investment up front on health IT in general and health information exchange, then the return on investment. And I think that one of the things that we're looking very carefully at the VA is what is that return on investment, because we have the long track record to assess that, and that's something that we're actively engaged in.
Okay. Let's move on to the next slide then. Now this is a somewhat busy slide. This was actually done, this is an earlier version, I think, of slides that you saw Doug Frisma and Marianne Yeager give. It's a busy slide. I actually sort of like it because, first of all, of course, it identifies integrated delivery systems, not quite in California, but somewhere near there, which is obviously where Kaiser Permanente is headquartered. But also speaks, I think, more importantly, the fact that, and once again, just to reiterate what Doug was sort of commenting, this is much more than technology. This is standards, this is specifications, this is trust fabric and agreements. And to my view, this is what has made the NHIN qualitatively different than many of the activities that we've seen before. Many of the previous activities have been primarily technology focused or primarily battles about standards. I mean, to my view, and I'll sort of say this at the end also, technology is probably the least of the issues here. It's really the agreements, and I know that the VA and DoD have spent probably a year working on the DRSA and the other agreements, trying to make this happen in a way that supports both specific federal needs as well as another healthcare organization out of the private sector, Kaiser Permanente.
Yeah, and I'll talk a little bit more about that when I go through. My talk's really going to be about. I'll talk about this a little bit more when I go through the VA's perspective about why interoperability with the private sector, and what's so important about using a national standards for that interoperability, and why did we choose the NHIN?
Okay. Next slide.
Oh, sorry.
I'm sorry. We'll go through this very rapidly because I think you've seen it before about the benefits of interoperability. Certainly continuity of care, portability are key. Let me also say, though, that I think we're all seeing that there's going to be, with federal support as well as important business needs, that I think we all believe that there's going to be continued rapid growth of health information exchange in the coming years. Of course, once again, it gets back to that it needs to be a single standard, so we aren't negotiating the standards as well as the agreements every time we seek to have yet another relationship. But obviously, this is something important going forward. Next slide. Now, let me jump into our limited production implementation. 2008, as both Marianne and Doug commented, was really a year of demonstration of capacity. We were showing that we could actually use the standards using test clinical data, demonstrating with the VA, DoD, others, other NHIN participants. I think in 2008 we became convinced that this was robust enough to move forward with. And so 2009 for us has been really a year moving from sort of concept, from demonstration, into what we describe as a limited production implementation. Obviously, we were proud to announce back in January that our limited production site went live in San Diego. We, of course, our signatures to the DRSA, and the DRSA was the Data Use and Reciprocal Services Agreement. The DRSA was, of course, fundamental to enabling us to move forward, and only took a small army of lawyers, which, once again, other users and other participants in the DRSA don't have to go through, because it has already had a lot of legal involvement and review, both on the federal side as well as by, once again, another private large delivery organization. But we've implemented the compliant architecture, the gateways, the message brokers, all of this sort of stuff. Now, I do want to emphasize, and I think this is something that will evolve, as I'm sure, as we move forward, but this is, for us, an opt-in approach, and I think also for the VA. We think it's important to move carefully and gradually in all of this stuff. This is, to my view, part of the trust fabric. We may feel differently, as well as the country may feel differently after 10 years of experience in all of this. But I think for the moment, yes, we trust, but I think the nature of the exchange really requires an opt-in environment.